Our case is PVCs induced cardiomyopathy. History of the patient is a male patient, 34 years old, not known to be hypertensive or diabetic or ischemic, with no family history of cardiovascular disease. He was complaining of exertional dyspnea and palpitation. The condition started 4 years ago by gradual onset and progressive course of exertional dyspnea and palpitation. 12 lead ECG show sinus rhythm with frequent ventricular ectopic beats in the form of PVCs and couplets. Echocardiography show dilated cardiomyopathy, ejection fraction 40%, with dilated LV in diastolic and in systolic dimensions. He started medical treatment, optimal medical treatment for heart failure and antiarrhythmic medication, including beta blocker and amiodarone, but he didn't show symptomatic improvement. Then he referred for us. We start to do 48-hour Holter monitoring, which show high burden of PVCs, which was 60%. It was show also couplets and triplets and non-sustained VT. We refer him for MRI, which show dilated cardiomyopathy with no scar on late gadolinium enhancement. He do CT coronary angio and it was normal. So our diagnosis was ventricular arrhythmia-induced cardiomyopathy refractory to medical treatment. So what to do next? According to 2019 expert consensus statement on catheter ablation, which states that in patients with cardiomyopathy suspected to be caused by frequent and predominantly monomorphic PVCs and for whom antiarrhythmic medication are ineffective or not tolerated or not preferred for long-term therapy, catheter ablation is recommended. So we decide to ablate these PVCs. Our roadmap, we start by localization of site of origin of PVCs by 12 lead ECG. From lead V1, as we see here, it is a right bundle branch morphology, which means that it comes from left ventricle. In inferior lead, it is a negative deflection, which means that is a superior axis and a posterior location. There is positive pericardial concordance, which means that is a basal location. And there is an S wave in lead V6, which means mitral annular location. So it's a posterior mitral annular PVC from surface ECG. And this is the algorithm we used to localize the site of origin of these PVCs. Then on the cath lab, our approach to LV, we have two approaches. May start with retrograde or transeptal approach. We prefer transeptal approach for is accessible for posterior mitral annulus and less vascular complication. By femoral vein access, we insert 6 French coronary sinus decapular catheter and insertion of molar sheath and introducer, do transeptal puncture by broken brow needle, and ablation catheter was introduced through Mullen sheath for mapping left ventricle. We use mapping system, Navix 3D system, and do activation map. In activation map, we search for the local bipolar EGM precede the QRS onset and unipolar signal which demonstrate a QS configuration. And found earliest site of activation was posterior mitral annulus. As we see here, this activation map. Okay. And the earliest bipolar signal was 32 millisecond before the onset of surface QRS complex. And this is a color code map for the origin of or early activation. We see the white color is the earliest site of activation. Sorry, video here. Okay. And we do propagation map, show that is a focal origin of the PVCs. We start the ablation by irrigated catheter at 40 45 temperature, flow rate 17 milli per minute. For 1 minute, PVCs was terminated, but recur after 5 minutes. When we ablate again, it was transiently terminated, then recur again. So we decided to use Agilis sheaths for better support, and ablation was started on 40 watt at temperature 45 with irrigated catheter, and also for 1 minute, flow rate 17 milli per minute. PVCs was successfully ablated with no recurrent within 1 hour waiting period. This is ECG, surface ECG, and intracardiac tracing during PVCs ablation. The frequency started to decrease and then completely ablated. After 3 months follow-up of the patient, ECG show no PVCs, echocardiography show improvement of ejection fraction. It become 47% with reduction of end-systolic and end-diastolic dimensions. So PVCs induced cardiomyopathy is a potentially reversible condition which LV dysfunction is induced by occurrence of frequent PVCs. Mechanical ventricular dyssynchrony may contribute to LV impairment. Predictor for development of cardiomyopathy including QRS duration more than 140 millisecond, PVCs coupling interval below 600 millisecond, high PVCs burden, which more than 10%, RV location and epicardial origin of the PVCs. Prediction of recovery time of ejection fraction about over 12 months. Take-home message: catheter ablation has become a reasonable first-line option in patients presenting with PVCs-induced cardiomyopathy. Surface ECG for localization of PVC's origin is an important guide for ablation procedure. Agilis sheaths help for better contact and support of ablation catheter for successful ablation. Thank you.